Thank you everybody for coming. Hopefully this will be a useful talk tonight. We're talking about menstrual health, and I've sort of subtitled this "Empowering You to Understand Your Cycle," because I really feel that the key to kind of having that understanding gives you so much power in terms of getting the treatment that you need when you can know what's going on in your own body, know what different conditions are out there and what symptoms might be causing the symptoms that you might what conditions might be causing the symptoms that you're experiencing. So my name's Leah Deutsch. I'm a consultant obstetrician and gynecologist, and I'm working at Clinic 51 at the moment. So hopefully this will be useful. And if there's any burning questions at the end, then happy to answer those. So, funny. So, tonight, what we're going to cover really, and just to give you a brief overview on the presentation, is looking at why it's important. So I've briefly touched on that already. And then understanding normal, because I think the key to understanding the abnormal is knowing what your cycle is doing normally. And then you can relate it into all of those conditions that we're going to come on to talk about. We're going to talk a little bit about common symptoms related to the various conditions that we're talking about. So what you might present with. There's a lot of overlap, just as a heads up beforehand, because I think, you were talking about pelvic organs, so the symptoms may be quite similar and there's quite a lot of nuance within those symptoms, but hopefully this will give you some key pointers into what, if you are experiencing difficulties, what might be going on. And then we're going to look at each condition in terms. There's quite a few that we're going to look at. So hopefully some of it will be relevant, some of it may not be relevant, but be interesting anyway. And give you something to think about. And then we'll go over and have a little question and answer at the end. So happy for you to put any questions in the chat, and Sonia will answer those and pass those over to me at the end. So why is it important? So in terms of our menstruating life, we spend almost 4 decades menstruating, having our periods. I mean, that's obviously variable for different women. Some will start their periods earlier, some later, but average age of starting periods is around 12 and the average age of menopause is 51. So, it may be later, so it may be even more, it may be slightly less. And it's estimated that up to almost 50% of women experience some kind of menstrual disturbance. So, if we're looking at the top number, that sort of 49% range, that's an awful lot of women that are experiencing some difficulty with their cycle. We know that only 1 in 20 women in that 30 to 49-year age bracket go to seek help, so see their GP about it. So when you're actually looking at, you're looking at 5% of women actually approaching their GP for help, whereas nearly half the population are actually experiencing them. So that tells us that there's a gap somewhere, that actually women are either sort of feeling that they have, maybe they think it's normal, or maybe that they don't trust their healthcare providers to give them the care that they need, or they're going elsewhere to try and seek maybe alternative support to help with their periods. So I think it's really key here to say that if you're having irregular, painful, or heavy periods, it's not normal. In the past those first few years after we start our period. So we expect there to be some irregularity to begin with, but it isn't normal past that. And it's also quite sort of taboo, I think, within our culture still. I mean, we talk about periods a lot more within the media. It's less of a sort of taboo word, but within different cultures, the periods are sort of perhaps felt to be less something that we can talk about, but also that feeling that, well, it's happening to all other women, so therefore this must be normal. And so it's difficult sometimes to approach help without feeling that maybe you're making a fuss. So let's look at a normal cycle. So this is something that I have been exposed to, I think, throughout my medical career. This lovely menstrual cycle, which you may be familiar with if you did any biology at school or in further education. And I found it always quite hard to get to grips with it. It took me a long time to kind of finally kind of understand, because you've got those 3 areas there. So the top one, we're looking at that top section, as you can see on the left, it says your hormone levels. So we'll come back to that just to have a brief understanding of it. But I think the key thing is those two bottom sections. So your ovarian cycle in the middle, that's what your ovary is doing. And then the bottom bit is where the lining of your womb, your endometrium. So it's showing the thickness of the lining of the womb and where bleeding happens. So I think one of the first things to say is I think a lot of women that come to my clinic might sort of not kind of realize when their periods start. And I think there's maybe some confusion over it. So we count day one as the first day that you menstruate. So the first day of your bleed is day one. And then up until the next period is the full 28 days, 30 days, however long your period is. And I'm just going to, sorry, admit. Don't know, Sonia, if you can admit somebody. So so when we're looking at those two different areas, your ovarian cycle and then the endometrial lining, that kind of gives us an idea of what's going on physically in our body, and then that top layer there is what your hormones are doing. So an average cycle is anywhere between 28 and 35 days. It may be a teeny bit shorter, like 26 days, 37 days. But if you're getting for anything really over 35 days consistently is considered a prolonged cycle. And then the average amount of time we expect you to bleed is 4 to 7 days. So if you're bleeding more than 7 days, then we consider that abnormal. There's, as I mentioned before, that we get that variation at the beginning of when you start your periods that men are key. So, sort of we think 2 to 3 years normally. It can go on for 5 to 7 years after you start your periods. So if you start your periods at 12 and they haven't settled down by the time you're 19, we'd start to think about what's going on. But I would say even if if it's been 3, 4 years after your periods have started and they're still troubling you, then I would definitely say it's a time to look at it and think about seeking some help. And then in those 10 years just leading up to menopause as well, we expect to see there'd be a shift in the pattern of the bleeding. They may become shorter or longer cycles, shorter or longer amounts of bleeding and volumes of bleeding. Another key thing to say is PMS symptoms are not normal. So just going back to that graph, just to kind of give a brief overview, because this ties in with a lot of the other conditions that we're going to talk about this evening. So in those first 5 days of your cycle, all your hormones are pretty low. Your body is recruiting a follicle from your ovary to start to grow an egg. And then in the first half of your cycle, your ovary is developing that egg. It's selecting an egg to grow and create, and then one of those eggs, it will select several follicles, and then one of those will become the dominant follicle. And then at the middle point, normally of your cycle, around about day 14, but it's very dependent on the length of your cycle, you will ovulate. And in that first half, your estrogen levels are going up and up and up gradually. And that often is when you have more energy, you feel a lot better. So estrogen is associated with feeling a bit more energized, a little bit more in control of things. After you ovulate, your progesterone levels start to rise as well. And then the progesterone, what that does is it thickens the lining of the womb to prepare it to receive a pregnancy. So progesterone classically can often make you feel a bit more sleepy, a bit more relaxed, and often is associated with mood symptoms within that sort of PMS spectrum that we're going to talk about a little bit later on tonight. So if you don't have a pregnancy, so if no egg is fertilized and implants in the uterus, the progesterone will suddenly drop and that will trigger a period. So just trying to bear that in mind as we talk about other things this evening. So common symptoms that you might experience would be irregular periods or infrequent periods, or even absent cycles, so not having any periods for months on end. You might experience pain with your periods or before your periods, very heavy bleeding with clots. Sometimes you might experience flooding, which is leaking, so you might be having to wear a tampon on a pad, for example, at night, and then having leaking on the sheets. You might be experiencing painful sexual intercourse. Bleeding between periods is not normal. Some people will have an ovulation bleed, which will be 2 weeks just before their period. So, but that's normally expected to be lighter. But any bleeding outside of that or bleeding after sex would be considered abnormal and something that you should seek help about. Then pain relating to your other organs. So obviously your bowels and your bladder are very closely related to your pelvis and your uterus. And so pain opening bowels or pain urinating or difficulty urinating can often be one of the other symptoms that we see. So what are these symptoms related to? Could it be an endometrial polyp, endometriosis? Irritable bowel syndrome is also very much, again, closely related. As I said, your bowel's very close to your uterus, so they're often very closely entwined. Adenomyosis, which we'll talk about, premenstrual syndrome, and PMDD, that spectrum disorder, polycystic ovarian syndrome, and then I've lost my slide thing, and fibroids, and ooh, and then pelvic congestion syndrome, which you may not have heard of. So we're going to talk about, we're not going to talk about irritable bowel syndrome tonight because I'm not a gastroenterologist, and I don't know if it will be, it may be helpful, but I think getting into that as an additional thing is perhaps less helpful. So we're going to talk about all of these conditions. So these are quite busy slides. I've tried to put a lot of information on there just in case you want to go back, and then you've got that information there. But we're going to talk about these terms a bit more broadly. So endometriosis may be something that you are familiar with. It's been a lot talked about a lot more in the press. A lot of soaps and mainstream sort of television programs are starting to include endometriosis when in their storylines. So I think there is definitely a growing awareness of this as a condition. So this is what happens in endometriosis, if you're not aware. Is there's a little, I put a picture down there because I think it helps explain it quite nicely. But when we talked about that cycle, sort of keeping that cycle that we talked about before in your mind, I think that can be also quite helpful when we're talking about endometriosis. So in endometriosis, what happens is the cells that are similar to those that line the uterus. So they're not the cells that line the uterus, they're cells that are very sort of biologically similar, will implant outside of the uterus. So they may grow anywhere. Most commonly they grow in the pelvis, but they can grow on the lungs, they can grow even in the brain. That's very, very rare, but commonly we found them in the pelvis. So they could be on your ovaries, or they could be on your fallopian tube, sometimes they're on your bowel. And because they are hormonally responsive tissues, in the same way the lining of the uterus is hormonally responsive and gets thicker with that progesterone that we talked about gradually going up, those cells also get thicker and more developed. And then when that progesterone drops because a pregnancy doesn't implant, they will bleed. And when they bleed, they cause pain because we're not supposed to have blood outside of the pelvis. It irritates the pelvic lining and it causes significant pain within the pelvis. And it also causes much heavier periods. So that can also contribute to pain when you're bleeding very heavily and your uterus is trying to expel excessive volumes of blood. So pain and heavy bleeding are the key markers of endometriosis. The other thing to say about endometriosis is when that bleeding happens, your body detects it as an injury. So in the same way, if you cut your hand, your body sends mediators to help heal that wound, to create a scar and to plug the wound, and to stop it bleeding, and eventually you'll be left with a scar. So your body is doing what it should do. It is recognizing that there's a wound in the pelvis and it's sending things to help heal that wound, and scar tissue starts to form. But because the bleeding is happening in an area where there shouldn't be any bleeding, what happens is that scar tissue might start to form between structures that shouldn't be connected. And it's a very gluey, sticky substance. So when we look at it, when we do surgery, it starts off almost looking like cling film. And then over time, if there's excessive bleeds and more thickening happens, it becomes a really thick, fibrous band of tissue. And so what you see sometimes is fallopian tubes being stuck onto the uterus, or the bowel being stuck onto an ovary, and parts of the body that shouldn't be stuck together are stuck together. It affects around 10 to 15% of women worldwide. And I think the issue here is really the massive significant impact that it can have on day-to-day life, both at work and school. But it can also have a massive impact on relationships, ability to stay employed, because if you haven't got an understanding boss and you're not able to go to work, for example, because you're in such severe pain, it can often lead to job loss. And I've seen that definitely with patients that I've seen over the years. So what we see is, along with the chronic pelvic pain symptoms, you might have pain during sex, and that's due to the fact of this scar tissue that builds up. Because when you haven't got any scar tissue, your pelvic organ should be able to move freely. So when you have intercourse, that your uterus and your tubes will move freely. If there is scarring that's there, things are stuck to places they shouldn't be, and so that will cause a sort of tethering and a pulling and a pain sensation with sexual intercourse. The other thing to talk about is infertility, which is really important. And so this is definitely not the case for every single woman that has endometriosis, and it's more about where the endometriosis is occurring. So it may be normally it's common if it's affecting the tubes that there may be some issues with fertility. So if there is endometriosis within the tubes, it can cause inflammation and the tubes will stop functioning the way that they're supposed to be. The other thing that can happen is that there's endometriosis, for example, on the back of the uterus, and the tubes are stuck to the back of the uterus, and so therefore they can't go and pick up an egg like they're supposed to. So the fallopian tubes are an incredible structure. What they respond to a chemical signal from the ovary. So when an egg is released, the fallopian tube will be attracted to it, will go over, and it will literally hover over the ovary so that it can pick up that egg and take it to down the tube into the uterus. In women that have had one tube removed, for example, if they've had an ectopic pregnancy and needed surgery to treat that, then we see the other tube taking over. So your fertility, if you lose one tube and one tube isn't working properly, then your fertility is actually only reduced by 20%. So the other tube will just take over functioning, which is really incredible when you think about it. So I think the key thing here is to say, first of all, we see lots of women who get pregnant when they have endometriosis. So not to be sort of like too over worried and scared that you may not be able to have children if you suffer from endometriosis, but also to seek help early. So if you are having symptoms, to get it treated, because the earlier we get treatment and suppress the condition, the less likely scar tissue is to develop and then end up facing those problems. So the main treatment options that we have are hormonal therapy. And I know that that's quite, I think, not necessarily controversial, but I think today lots of people don't particularly want to necessarily have extra hormones that they take in the form of a combined pill. And that's totally understandable. But I think when we think back to that chart that we looked at the beginning of this talk, sort of to understand what's happening, and that actually that cycle is what's causing these bleeds to happen and causing the disease to worsen and spread and cause the symptoms. If we suppress that cycle by using the contraceptive pill, it can be really beneficial in terms of treating the symptoms. So there are various things like the combined oral contraceptive pill. We have newer progesterone treatments, progestogens, which are really, really excellent at treating endometriosis. Things like the hormonal coil is excellent as well because it acts more locally, so you get less of the systemic side effects that you might do with a contraceptive pill. And then I've put GnRH agonists there. These are a class of medication which are more reserved for really severe endometriosis, where women are considering even having a hysterectomy because their disease is so bad. And this essentially shuts off the ovaries completely. So it puts the woman into a temporary menopause, and that's reversible as soon as it stops. But what it gives us, what it gives the patient is a kind of a disease holiday. So they have a little break from that. They get potentially some menopausal symptoms, but we can add back to help with those menopausal symptoms. And so as I say, this is an extreme end because obviously it's a medication which has its own side effects, but it can tell us actually, are your symptoms worse when we take away that cycle? And if they are your symptoms, better when you take away the cycle? And if they are, then women might consider potentially down the line having something like a hysterectomy. And that really is the most radical treatment for endometriosis, completely removing the ovaries and the uterus potentially. So other ways that we can treat this, with diet. So it's been shown for some mild endometriosis, like reducing the amount of dairy and other inflammatory things like refined sugars can be helpful with symptoms. We can also use symptomatic relief with pain relief, so analgesics. We use particularly tranexamic acid and mefenamic acid. They're in the same class of medication as things like ibuprofen. And what they do is they reduce inflammation, but they're very much targeted towards pelvic pain. Tranexamic acid is very good for heavy bleeding, and mefenamic acid is very good for pain in periods. And then we use surgery as well. So keyhole surgery normally to remove the endometrial tissue when there's really severe disease, and that can give us an absolute diagnosis. But we don't need to have surgery to get a diagnosis. We can do it based on symptoms and response to treatment. And I think it's really important to say that surgery is not always the answer, because surgery in itself can cause more scarring, because we're causing, an inflammatory response in the pelvis. It can be very helpful where clearance is needed. But the thing with endometriosis, very sadly, is that we don't really know why it actually happens. There's loads of research going into it in the moment. We feel there's definitely a likely hereditary element to it, so genetic, and it's thought that there may be an autoimmune response going on. Historically, we used to think that what was happening here was that there was tissue that from the endometrium, so the lining of the womb, going into the tubes and coming out into the pelvis, and we call that retrograde menstruation. And actually, that's not what's happening, because we see it, as I said before, in the lungs, in the brain, and that couldn't be the case if that's the process that was happening. So we think it's a more complex process than just something as physical as that. So that's a very long look at endometriosis, but I think it's a really common condition and it's a thing that people want to talk about. So hopefully that would be helpful. Now, adenomyosis is another condition which is actually very similarly related to endometriosis. So I'm not going to spend as much time on this because the process is very similar in terms of what's going on. But in adenomyosis, what's happening is the cells that very similar again, like endometriosis cells, similar to those that line the womb, are growing into the muscle wall of the uterus. And so in the same way as those endometriosis cells responded to that hormonal fluctuation through the cycle, so do these cells in adenomyosis. So they bleed into the muscle wall, causing very heavy, very painful periods. And over time, the uterus becomes a lot larger and sort of quite bulbous. It's more common in the older age group. So we see endometriosis more in that sort of younger group as you kind of come into your early 20s, late teens. Whereas this is more in that sort of 35 to 50-year age group. So we think there's a prevalence of up to about 40% in women. It's much more common in that 41 to 58-year age group. So we can see that 60% of cases will occur in that slightly older age group as we start to approach menopause. And these are the symptoms, again, very similar to endometriosis: heavy bleeding, very severe pain, often bowel symptoms as well with this, and you might have much longer periods. And the treatment is very similar because the process is very similar to endometriosis. Dynagest is a progesterone, and is really helpful for both endometriosis and adenomyosis. It has a less poor side effect profile in terms of a hormone, and it's very effective they've done several studies on this particular progesterone, which is helpful for endometriosis and adenomyosis. I would definitely say if you're suffering from adenomyosis and you're not looking to get pregnant, the Mirena coil is a really, really good option here. And then most radically, a hysterectomy again. So polycystic ovarian syndrome. So this is a slightly different kind of class of condition. And I've put a little picture there that's nothing we've designed. It's from Everyday Health that I've pinched off the internet. But it's quite good because it tells you kind of all the different symptoms that you might be experiencing with PCOS. Now, PCOS is a bit of a misnomer because we talk about polycystic ovarian syndrome. So you don't actually have to have polycystic ovaries to have PCOS. It affects around about 18% of women, up to around 20% is normally what's quoted. But you only need 2 out of 3 criteria that I've listed here. So you might experience irregular ovulation. So that means you might have irregular periods. So by that, I mean periods that are either less than 28 days or more than 35 days. So 1 month, you might have a period that's three weeks between periods, and then you might have a 6-week gap or a 3-month gap, and then another period. And the periods when they come are often very heavy. Elevated androgen levels is the other criteria to get a diagnosis of PCOS. And androgens are things like testosterone. So they're hormones that we produce. Classically, we think of them as the male hormones, but as women, we produce testosterone as well. But those levels are much higher in PCOS. And that causes a lot of the symptoms that we see with PCOS that are more physical. So unusual hair growth, so facial hair growth or on the chest, hair thinning on the head, acne symptoms on the face. And that can either be the symptoms, so you see somebody and you see that they have that physical appearance, or they may not actually have any of those physical appearance, and we do a blood test and we can see that their levels are elevated. And then the third criteria is polycystic ovaries on an ultrasound. So these are not big cysts, these are not ovarian cysts, these are small little cysts where your ovaries are trying to recruit lots of eggs, but it's just not working. Polycystic ovarian syndrome, again, there's a lot in gynae, I think, that we don't really know why these things happen. And I think that's probably a marker of the fact that we deprioritize women's health, and we have historically deprioritized women's health. I think there is a slow shift moving towards improving things, but I think that's the reason why we just maybe don't have the answers, and they will come. It's essentially what we consider a metabolic disease. So although it's affecting the ovaries and the sort of reproductive system, it's actually an endocrine disorder, a metabolic disorder, which affects our hormones. So what happens here is that we start off with insulin resistance. So insulin resistance is the same thing that you get in diabetes. So insulin is a key which acts in a cell to unlock it and allow sugar to get into it for our energy. When you have insulin resistance, that key just doesn't work as well in the lock. So your body senses there's all this glucose that's floating around in our bloodstream that needs to get into the cell. So it pumps out more insulin to try and get this sugar into the cell. And then you have lots and lots of insulin floating around in your body, which your body doesn't like. And that promotes increased testosterone production, which leads to all of these symptoms. And that testosterone in turn has an impact on our ovaries, causing more of a recruitment. It disrupts our menstrual cycle. So our cycles tend to be what we call anovulatory. So you might have a period, but you're not actually ovulating as part of that period. Most women with polycystic ovarian syndrome tend to have really infrequent periods, and they are and they're not ovulating with that, as I mentioned. They also really struggle with weight gain because you have that increased insulin resistance. It's harder for your body to produce to lose weight because our metabolic rates are lower. And so it can have a really big impact on self-esteem when you've got sort of women who are not meeting these sort of social stereotypes of what a woman should look like. I'm putting that in inverted commas. But sort of the facial hair growth, the women having problem with obesity, the hair thinning, and the acne. So it's a really difficult problem for women going through this, because it's not only that they're having these physical symptoms, but that psychologically it can really impact their self-esteem. So in terms of how we treat it, the biggest thing we can do is a lifestyle modification, and I can't stress this enough. So when we lose weight, we have less fat cells, and all of the insulin resistance improves when we're carrying less weight. So in the same way that we see with people with diabetes, we encourage them to lose weight when they're starting to move towards that diabetic sort of threshold. It can be really, really beneficial to kind of stabilize hormones to bring our weight back down. And I would say with that, it doesn't need to be BMI, body mass index, is what we use to calculate these things, but it actually it's not the greatest tool. And actually building muscle is really key here, and that will help improve metabolism. So doing exercise is really a really great way to control this, as well as having a healthy diet. So improving your gut microbiome has been shown to improve how we process estrogen, and we process that because we're producing extra estrogen, and this is the problem. So all these extra follicles are stimulating lots of estrogen. If you remember that beginning bit of the cycle when the estrogen is going up as the follicle is developing, but we're not actually getting periods with PCOS. So we're having lots of follicles developing, estrogen levels going up, the lining of the womb thickening. And this over time can lead to issues around precancerous cells in the uterus. So when the lining of the womb is stimulated excessively, it can then cause cellular changes, which can lead to these precancerous cells. So it's really important for women that have PCOS to have a minimum of 4 periods a year. And so that is a large reason why one of the biggest things we kind of recommend is to use hormonal contraception to regulate the cycle, not only to help with predictability, but also to protect the lining of the uterus. And that doesn't necessarily have to be a monthly pill. It can be that you just take some progesterone to induce your body to create a withdrawal bleed. So in the same way we produce that progesterone goes up in the second half of the cycle, and then when the progesterone drops, you have a period, you can take progesterone for 10 days, stop taking it, and that causes the lining of the womb to shed to protect it. The other thing that we can use is metformin. So that's classically a diabetic medication, but we use it often for women that are suffering with this insulin resistance in PCOS to help improve that sort of cycle that we were talking about before. It's also really beneficial in women wanting to conceive, so it improves the likelihood of conceiving. So again, really, really useful medication. It's not licensed for this use, but as gynecologists, we do prescribe it. The other thing we can use for women that are suffering with these androgenic side effects, so the acne, the hair growth, the hair loss on the head, is spironolactone. So spironolactone is a diuretic medication classically, but it does reduce our androgen levels as well. So we use it for that purpose, and that can also be really helpful. And then fertility is the biggest thing. So for a lot of women, if they're young when they're taking it, because you're not ovulating. So, but there are lots of options, like I alluded to before. Metformin is really helpful for fertility treatments, and there are various other things which I'm not going to go into tonight because that's a whole nother talk, but there's lots of other options that we can use in terms of helping people get pregnant if that's something that they want when they have PCOS. And it certainly is not that you have PCOS and you can't get pregnant, because some women will ovulate. Especially I see lots of women who have PCOS who are maybe within a normal BMI category actually, and don't have any of these androgenic symptoms, but they have PCOS on their scan, at their polycystic ovaries on their scan, and they're having irregular cycles, and they have that diagnosis, but they still are perhaps ovulating, and so therefore they don't have any issues. And we definitely see plenty of women who have PCOS who do get pregnant. So just wanted to sort of just make that point that PCOS does not mean necessarily issues with conceiving, but if you are having issues with conceiving, seeking help early is really key, so that you're not suffering for years on end without getting pregnant, because there is help out there. So fibroids, so as we move our way through the various gynecological conditions, and we're sort of over halfway through now, so I know there's a lot of information here, but hopefully this will be helpful. So fibroids are benign tumours of the uterus. They're really, really common. We think around 30% of women will have them by the age of 35, and by 50, 70%. So that's a huge amount of women that might have them. There was a US, so classically we think they're more common in Black women than white women, but there was actually a study in the US of women who are at the age of 50, and it was shown, and 70% of those white women would have fibroids, and 80% of Black women. But historically, we tend to say it's 2 to 3 more times more common in Black than white women. And these are, as I say, these are benign tumours. They can be really small. So that's of 70% of women may not even know that they have a fibroid. They may be really teeny fibroids that are not causing them any issues at all. But as they grow, and they grow really slowly over time, and they grow because of the estrogen we produce. So when women go through menopause and their estrogen levels drop, they tend to get much smaller and start to shrink. And again, that is one of the kind of rationale behind some of the treatments that we recommend. They can be anywhere within the muscle wall. So I've got this picture down here, as you can see, and this is a uterus, and at the top, the tubes that are coming out, and there's sort of little finger-like hands on those arms of the uterus holding over the ovaries, and those white things are the fibroids. So the fibroids can either be on the outside wall of the uterus and they bulge out, and these can be a real problem because as they get bigger, so if they're very small, they're unlikely to cause any issues. But I've seen fibroids that are really large and almost the size of a football. They can be. I mean, it's rare to have them on that large, but sometimes they can get that large. And then what happens is they start to put pressure on other organs. So they can put pressure on the bowel, on the bladder, in the tubes that connect the bladder to the kidneys, and start to cause pressure on the backflow to the kidneys, causing kidney failure. So they can be a really serious problem in terms of what impact they have on other organs. They can be in the middle wall of the uterus. And when they're very small, you wouldn't even notice them. But again, as they grow, the uterus will grow with it. And then fibroids that are inside the uterus, so inside that sort of line, pushing onto that lining of the wall, you can see how it's disrupted. You haven't got that little sort of triangle shape there. You've got that submucosal fibroid, which is the fibroid just under the lining of the womb. And that disrupts the lining and therefore causes heavy bleeding. I mean, all fibroids as they get larger. So we tend to see the effect of fibroids when they get over that 3 centimeter mark. So fibroids less than 3 centimeters, we don't normally do anything about. We tend to just watch them. But fibroids that are perhaps 2 centimeters, if they are in that position, can cause issues with bleeding because of that disruption of the lining of the womb. And that can also cause issues if they are in that position, that submucosal fibroid, with fertility, because the pregnancy can't necessarily implant unless there is a nice smooth lining to the uterus. So again, very similar symptoms we were talking about. Women with fibroids tend to have very heavy periods, and this can be a real issue around things like anemia. So they may suffer from tiredness, shortness of breath, heart palpitations, just feeling really, really flat and like they've got no energy at all. And so it's really important that we check iron levels to make sure that they're not anemic. But the key thing here is turning off the tap. So we can replace the iron and make them feel better, but also we need to make sure we turn off that tap and stop the bleeding, because anything we're putting back in is just being lost every month. And so again, I mean, it sounds like a broken record, and like the treatment for lots of these things is very similar. So in terms of the hormonal therapy that we recommend, tranexamic acid is quite a key here. So hormonal therapy is less important for actually modifying the fibroids themselves. It's more about controlling symptoms, so trying to stop periods. Tranexamic acid was the one that I talked about before, which is very similar to ibuprofen, but it basically stops bleeding. But we can only give that for 5 days at a time, because the way it works is it increases your blood's ability to clot, so it stops bleeding, it clots off the blood. But if you take it for prolonged periods, it can cause increased chance of you developing a blood clot in your leg or your lung, which is obviously a serious complication. So we don't want to prescribe it for long periods of time. So this is really for people that are having very short, heavy periods. So a sort of 4 or 5 day period, they can take it for that period to help reduce bleeding. But if periods are kind of going on for weeks at a time, that probably isn't the best treatment for them. There are other sort of minimally invasive surgical procedures. So there's a procedure called uterine artery embolization, which is where we go in the groin. We don't do it as gynecologists. This is done by interventional radiologists, which is basically a radiology doctor who does procedures, and they go in the groin, and they track a catheter, so a tube, into the main artery that feeds the uterus, and then they block it off, and that causes the fibroids to shrink. The fibroids will still be there, but they'll become much smaller, and it can be beneficial in women who don't want to have a major surgery if they've had lots of surgery in the past. But it'll be dependent on the number of fibroids and where they are. So we would normally do an MRI before we do that, just to assess where the fibroids are. And then other surgical options are things like a myomectomy. So a myomectomy is basically essentially removing the fibroid. And we can do this via keyhole surgery, a laparoscopy, or an open surgery if the fibroids are really, really large. And you can see that little picture there. So those are some fibroids that have been removed. Those aren't actually that big. They're sort of probably about golf ball size, but we can see them that are much, much bigger than that. And as you can see, there's sort of white gristly tissue, and then there's lots of little blood vessels around them, which is supplied, which is sort of taken from the main blood vessels. And as I say, they are impacted by estrogen. So endometrial polyps, let's just do a brief overview of that because I'm conscious of time. This is just worth to mention because they can be a common cause of and a very fixable cause of heavy bleeding. So again, really, really common. Again, up to 30% of the general population, with 40 to 45 percent of postmenopausal women having them. They have got a chance of becoming malignant, so developing into a cancer. That's quite a large range that I've written there. We tend to say that actually it's much lower than that in the whole. In postmenopausal women, it's higher. So we say in postmenopausal women, if they have a polyp and they are bleeding, so they're having symptoms from that, then there's about a 5% chance of it being a potential cancer. But in women that are sort of premenopausal, it tends to be much, much lower than that. So we'd say probably less than 1 to 1%. And so if you're not symptomatic at all, it tends to be that we can leave it if you're premenopausal, but it would be totally acceptable to do a procedure to remove it. And the procedure we do is a hysteroscopy. So I've put a little picture here. So it's essentially like a little metal tube that goes in through the vagina and then into the cervix, and we use water through the tube with a light at the end, and the water expands the uterus so that we can see, and it has a camera inside the tube to look around the uterus so we can target that polyp and then just remove it. And it can be done either under a general anesthetic. We often do these awake now. It depends on the individual, and it's really important to have a conversation about that and whether it's acceptable. The benefit of doing it awake is that you don't have to have a general anesthetic. The other thing to say is that if you're not really symptomatic, hormonal therapy will often shrink a polyp. So we use progesterone. Something like a hormonal coil is also really, really effective at shrinking polyps. So pelvic congestion syndrome, penultimate condition here. So this is a condition that I think, as a gynecologist, is probably really not very well understood or talked about. Throughout my training, it's definitely something that I heard lots of people sort of almost didn't believe it was a thing or that it existed. There's a lot more research coming out about it now. It's definitely a thing. It definitely exists, but it tends to be a diagnosis of exclusion. So if we've done various scans or surgeries or other treatment and we haven't reached a diagnosis, then we'll potentially look at this, which I think is perhaps a perverse way of looking at it, because actually if this is actually a condition, which it very much is, then why are we not addressing it and considering it in the same remit as endometriosis and fibroids and all these other things? So 30% of patients with chronic pelvic pain have pelvic congestion syndrome. So, nearly a third, that's a lot. And it's about 15% among that group where we have unexplained chronic pelvic pain, where they haven't had a diagnosis for other conditions. And it's about 21% of women who are premenopausal have it, but it also occurs in postmenopausal women. So they may have ongoing pelvic pain, but they don't have a period anymore, but they're still having this pain. We tend to diagnose it later, so in the third or fourth decade. So in your 30s and 40s is when you might be seeing it, and that is, because normally you've gone through various other investigations and nothing has been found, and so it's taken that time to be able to identify it. But also because it is more common in women that have had more children. It's common in women who are more obese and have a sort of more sedentary lifestyle. And so what is it? Basically, what happens is it's essentially like varicose veins in your pelvis. So the veins in your pelvis, like veins in your legs or in other parts of your body, can start to become what we consider incompetent. So that's perhaps not the nicest word for those poor veins, but basically your veins don't have a natural way of pumping. So our arteries, which carry all the oxygenated blood around our body, so arteries carry blood from our heart, which is oxygenated to all the organs of our body, and it has, within the wall of the artery, it has a pump within it pushing the blood around. Veins don't have that. They are simply a tube, and what they rely on is the tone of the tube, and also the muscles around to kind of help create that pumping action of the pressure back into the heart. So when these veins become dilated, what happens is it's not necessarily the issue is in the vein itself. Because they're dilated, that pressure in the system drops, like in a plumbing system. And so there's this sort of back pressure towards the arteries. So there's the oxygenated blood is not getting to the tissues enough. And so because that oxygenated blood isn't getting to the tissues, that causes pain. So in a heart attack, the reason why you have a heart attack is because your blood isn't getting to your heart and the tissue starts to die. So in the same way, when you're not getting oxygen to those pelvic organs, enough oxygenated blood, it causes pain from the basically tissues not sort of being deprived of that oxygen. So this is a condition in men. This is a very recognized condition called a varicocele, which is treated. So why it's not recognized in women, I'll leave that to you to kind of make your own kind of conclusion on that. But it is, it's a condition that is treatable, and it's a condition that is very real and very debilitating for lots of women. So the key symptoms of this, I think, is people that are experiencing chronic pelvic pain, so over 6 months of duration. Classically, this is pain that is worse on standing. So you may wake up in the morning when you're flat and have no pain at all. And as soon as you start to move and stand up, gravity kicks in, the veins stop working as well, and that's when you get the pain. Deep pain during sex, so pain inside the pelvis when you have sex is also common with this condition, or just after sex because there's an increased blood flow to the pelvis when we have sex, so that can exacerbate symptoms. And then because the veins in other parts of the body are likely to not be working as well, because it's a global thing that you don't tend to see just veins in the pelvis not working. It tends to be everywhere else in the body. So people will often experience symptoms like dizziness. So there's a condition called POTS syndrome, which again is something where people, when they stand up, they feel very dizzy and we don't know kind of quite what's happening. But again, it's likely to be related to that, and severe fatigue symptoms with it. If you've experienced a pregnancy and you've had varicose veins around the vulval area, that's quite an indicator that, if you have that and chronic pelvic pain, it's very likely to be pelvic congestion syndrome or varicose veins in your legs. So again, we can treat it with hormonal contraception. There's a class of medication called phlebotomics, which helps improve that venous tone in the vessels to help improve that blood flow. Pain management medications, but that's a bit of a sticking plaster. It's not actually curing it. So the kind of gold standard here for treating it is an endovascular treatment. So that basically means, in the same way those fibroids we were talking about putting a catheter in that groin to cut off blood supply to the artery of the ovary. This is here. I've got a picture here. We use it in the veins. So we basically we block off the veins and that helps improve that backflow. And it's really effective at treating women with this condition. So I've left this to last, premenstrual syndrome, and then premenstrual dysphoric disorder, because it's a sort of separate thing in terms of mood symptoms, but it's a very important thing to talk about. So when I talk about this to people and my patients that I see, I talk about it as being a spectrum of severity. So PMS is a spectrum. You may have mild mood disturbance, you may have really, really severe at the other end of the scale. So about 40% of women will experience some kind of symptoms of PMS, and we think around 10%. I mean, you can find mixed reports in terms of what the prevalence of PMDD is, but I think 10% is probably actually more realistic, and that's what current data is suggesting. So to get a diagnosis, you need to really be having physical or psychological symptoms that are occurring in that second half of the menstrual cycle. So when we were talking about after ovulation, and that get better once you have had your period, and then you have a normal period of time for a couple of weeks, 2-3 weeks, and then it starts again after ovulation, and it tends to happen every month, and it's been going on for at least 12 months. So those are the kind of criteria to get a diagnosis. This is caused by a hypersensitivity to hormones. So it's not that you're producing more hormones, it's just your brain is responding in a different way to the hormones than other people. So it's caused, we don't again, another thing we don't completely understand, but essentially progesterone is broken down to a product called allopregnanolone in our body. So natural progesterone that we produce is broken down to allopregnanolone, and it tends to be the mood symptoms that are associated with PMDD and PMS tend to be due to that allopregnanolone that we produce and the response of the receptors in our brain. So it can become worse at perimenopause just because of the fluctuations in our estrogen, because estrogen also has an impact. So estrogen has an impact on our serotonin levels and our noradrenaline levels, which are two of the hormones that we produce, that and neurotransmitters, sorry, that we produce that cause help improve mood. So they can have a big impact on it. So the biggest symptoms we see are sort of a variation of mood symptoms. It could be low mood, anxiety, irritability. Physical symptoms tend to be things like breast tenderness and bloating and headaches. Very tired in that second half of the cycle with sleep disturbances. So hypersomnia, which basically means not be either being really, really sleepy or not being able to get to sleep and having a sleep disturbance. In PMDD, which is that severe end of the spectrum, we can often have symptoms that relate to suicidal thoughts, so thoughts of self-harm, which then get better in that second half of the cycle, which can be really incredibly scary to lots of women. And I think it's sort of a real indicator of why we need to take this seriously, because it is dismissed, I think. And, I think historically, I mean, I think especially in the sort of the 80s and the 90s and probably in the early 2000s, we kind of, and probably even still, we kind of, mocked women. It's, sort of it's like, oh, is your period due? And that kind of like sort of making a joke about sort of irritable, grumpy sort of women in that second half of the cycle. But it's a very real physiological process that's happening. And, for some women, really catastrophic. So yeah. There are various things that we can do to help treat this. So, starting at the sort of lifestyle changes, regular exercise and stress management are really key. Dietary modification, so having like a really, it's all the things that we talk about all the time, like sort of a very like a high fiber diet with whole grains, trying to improve our vitamin B6 levels, and we can take that as a supplement. There is some data around magnesium as well. I mean, magnesium I think seems to be good for everything these days, but again, limited evidence, but it can be helpful just to kind of keeping an eye on your diet and sort of, if you're eating a lot of refined sugar, a lot of processed food, that is not going to be beneficial to your hormone levels and how your body is working. There's psychological therapies have been shown to be really effective. So cognitive behavioral therapy, we're basically reprogramming how your body is kind of interpreting what's going on in your cycle, and can be really helpful for managing these symptoms. Again, hormonal therapy. It seems counterintuitive. Why would we give hormones when it's hormones that are causing the problem? But again, what we're trying to do is kind of even out and stop that peak in progesterone and that drop in progesterone that's causing them. And stopping that, yeah, the fluctuation in the estrogen, because then we can increase your levels of serotonin and noradrenaline. So we're using it in a different way, than kind of about, it's not about regulating the bleeding, it's about helping manage those hormones which are affecting your brain chemistry. The other thing about that we use quite commonly are SSRIs, which are a class of antidepressant. This can be really helpful for people that are experiencing severe symptoms, and it's not something you have to take all the time. So some women find it helpful just to take it in the last 2 weeks of their cycle. So you don't have to take it in a continuous way. It can just be a cyclical thing that and that's often very effective. And they're both, taking it continuously or taking it for 2 weeks of the cycle, is being shown in trials to be just as effective as each other. So that's a very, very valid option for people that are really struggling. And then physical symptoms, managing them symptomatically, so we can give diuretics for bloating, and pain relief for cramps. So that's a huge, I realise, a lot of topics to cover, and thank you for your patience and sitting and listening. I hope it has been useful. I think the key here is there's a really big crossover between a lot of these symptoms and between conditions. I've popped here just some of the things to seek medical attention for if you're experiencing them. So if you're requiring to change your pad or your tampon every 1 to 2 hours for several hours over a day, where your periods are lasting for more than 7 days, or you're having severe pelvic pain, bleeding between your periods, or if you're bleeding after menopause. And really key, I think the biggest thing is if your symptoms are affecting your quality of life, and work and school, that's when you need to seek help, because it's just not acceptable that that's happening, and we shouldn't be dismissing it. And I recognise that there are medical professionals that do dismiss it, but hopefully this talk will have given you some real tools to have that understanding and being able to advocate for yourself when you see your healthcare professional if you're not getting what you want. There are various things that we can do that I've listed here, and I've kind of touched on them before in terms of getting a clear history, various scans and blood tests that we can do. So really just reiterating one more time that it's really key is understanding here so that you can advocate for yourself. The key is early diagnosis, because then we can treat you, and then hopefully that will lead to less problems long term and prevent complications lifelong. And that we need to individualize treatment, although there is a big crossover between various treatments for different conditions. It's about working out what works with you and your lifestyle, and what is going to suit you best. And just a reminder that heavy menstrual bleeding and pelvic pain are not normal parts of being a woman. There is effective treatment that are out there. So that is the end of my talk. If there are any questions, I'm happy to take them now.